Good afternoon, everyone, and welcome to the Department of Geriatric Medicine Grand Rounds. This CME activity is jointly provided by the Queen's Medical Center and the University of Hawaii Jabson Department of Geriatric Medicine. Now, before I introduce our speakers for today, I'm going to give some logistic announcements. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required to get CME. You can find the evaluations by following the link in the chat at the end of this presentation, or in our email advertisements, or in our website. CMEs will be sent out by our sponsors in mid-January every year. Your comments are very important to the planning committee and will be used to plan future programs. So please do give us your suggestions. It's my great pleasure to welcome our speakers for today. I do want to acknowledge that we have a change in speakers. Dr. Poki Balaz was supposed to be speaking today, but unfortunately she's unable to speak because she's not well. So at the very last minute, we are so grateful that Dr. Gina Fujikami and LJ Duenas jumped in and are going to present on the same topic. So I'll start with Dr. Fujikami. She's an outpatient geriatrician at the Queen's Medical Center and a clinical assistant professor of geriatric medicine at the University of Hawaii John A. Burns School of Medicine. She's a proud board member of the Alzheimer's Association Hawaii chapter and chair of the Alzheimer's Association's Care and Support Committee. I've personally known Gina since she was a first-year medical student, so very, very long time ago, and it's been wonderful to see her great career trajectory. Our second speaker is going to be LJ Duenas. He's the executive director of the Alzheimer's Association Hawaii chapter. And after Dr. Fujikami's presentation, he will be providing an update on the Silver Alert program that they just got passed by the Hawaii State Legislature. So please welcome Dr. Fujikami and LJ Duenas.
Okay, hi everyone. Can everyone see the screen?
Yes, we can.
Okay, great. Thank you so much. Thank you for the kind introduction, Dr. Masaki. And again, I wouldn't be here if it weren't for you. So it's all your mentorship over all these years. So apologies, I'm not Dr. Puki Ibalaz, who's our wonderful Alzheimer's Association board member and advocate. She's under the weather today, so you're stuck with me, but you also get LJ, who's again the executive director of the Alzheimer's Association. So I'm going to be talking about, on behalf of Dr. Balaz, about wandering and dementia. All right. So I recognize most of you on the video today. So I know all of you have had patients who have wandered at some point, or even family members who are suffering from cognitive impairment and who are at risk or are wandering. So what is wandering though? So it's getting lost or becoming confused about where one is. 6 of 10 people with Alzheimer's wander at least once during their life, during their disease course, which is just astounding that we don't hear more of these cases in the news. And LJ will talk more about that later. Wandering is, of course, very stressful, not only for the patient suffering with dementia, but a lot for the caregivers as well and the community. And wandering can be dangerous. So there was several cases last year of people who have wandered, unfortunately. One that sticks out in my mind is Mr. William Burr, who you might have heard on the news, did wander from his home in Mililani back in October of last year. And he was only 79, suffering with cognitive impairment. And unfortunately, he was found several months later, passed away. He was actually never found alive again after he wandered from home. So this again just highlights the importance that wandering is a big safety issue in our patients with Alzheimer's and all types of dementia. So who is at risk to wander? Everyone with dementia is at risk of wandering. They don't recognize familiar places. They may still be living in the past. I've had a patient thought they were still in Hilo working when they were actually in Oahu living at home with their daughter because of the memory problems. That because they oftentimes the past is more real to them than the present, they may try to leave the home to go to work or go somewhere with a long lost friend, even though they have been long retired. Wandering, just like in the case of Mr. William Burr, is very dangerous, as half of the people who wander and are not found within 24 hours will likely be injured or die. So time is of the essence when a patient does wander. So some cues that may indicate that a loved one with dementia could be at risk for wandering. They may say, again, I need to go to work when they are actually long retired. They're restless, pacing around the house, or they go for their usual routine walk, but they're coming back maybe an hour or two later than expected. Or even in the house, they can't remember how to get to the bathroom. Again, that feeling of not being in their home, and they may try to get to their old childhood home and not recognizing their current home as the safe place, is a cue that they are at risk for wandering. Being lost in friends' homes, grocery stores, etc., and also being more anxious in crowded areas where a lot of that anxiety and restlessness comes out can also lead them to be more at risk of wandering. So as a provider, whether a physician, social worker, nurse practitioner, even a concerned neighbor or loved one or caregiver, how can you assess someone with dementia who is at risk for wandering? Well, again, do a good interview, see again what the patient's behaviors are like and what they're currently doing at home right now. You definitely want to interview the caregivers or whoever's involved with the patient's day-to-day life. If you're a provider, so physical exam, looking to see how mobile they are, could be a risk factor. Of course, looking at their medications, polypharmacy, Beers criteria. Are they on any anticholinergics or opioids, narcotics, or benzos that could promote more confusion? Doing a baseline cognitive exam to know what stage of dementia they are at too is very helpful. Behavior exam, again, I mentioned that anxiety component that can put them at risk for wandering. So looking for dementia-related behavior disorders like anxiety, restlessness, irritability. Knowing the environment of the person suffering from dementia is important. Are they in a condo? Are they in a house? Is the yard locked up? So looking who's living at home with them, who's at home with them during the day is important as well. And then, of course, using the tools that we have in the clinic, whether it's the NPI, the MOCA, the SLUMS, using your tools to assess the patient's current status of the dementia. And then you want to also talk to the patient too, like why are they tending to wander? Again, are they looking for their old childhood home? Are they looking because they have to go to work? Why are they thinking they need to leave the home? Is important on how to try to do behavioral modifications with them in the future. Again, like I mentioned, getting the layout of the home, the gates, the doors, alarms, seeing what kind of routine the patient has, who's at home with them. Are they doing any activities in or outside the house? Again, how mobile are they? Do they still have access to the car? Can they still walk out of the home, or are they pretty frail and can't walk? You can also gauge for risk of wandering. Again, who's involved in their care, whether it's neighbors, friends, or family. Validation, redirection are all important. And then, as we know, the Alzheimer's Association, of course, is a great resource for caregiver support and education about what we're talking about today. TIPA Snow, we're all familiar with, has a lot of good behavioral techniques and tips. And then there's also the Savvy Caregiver program as well. So pharmacological treatment, so getting more to the medical nitty-gritty. Again, if there's an anxiety component, you may want to consider antidepressants, anti-anxiety medicines, but of course you have to have the conversation of the risks and benefits with the patient and with the family as well. You always do want to do the mantra in geriatrics, start low, go slow. If the antidepressants don't work, and I see Dr. Liu on the call, but there's also other classes of medications you could consider, and second generation antipsychotics, anxiolytics, mood stabilizers, other anti-anxiety medicines you could try as well to try to help keep the patient's anxiety and restlessness down so that they're not as risk for wandering. Melatonin if they're having trouble sleeping. So there are some there are some pharmacological treatments out there that could help to try to prevent wandering. But again, the point is not to sedate them or immobilize them, but it's try to help kind of take the edge off of things so they don't have a person with dementia doesn't have that tendency to want to leave the home. Again, the medications may be helpful. But really what it comes down to, again, in geriatrics is behavioral modification, right? So you want to live in their reality. That's what we kind of all preach. You know, the patient living with dementia really truly believes that they need to go to work. And of course, you know, if you try to persuade them or confront them or argue with them, it's just going to make things worse. So you really don't want to confront or correct them or yell at them, of course, unless they're in imminent danger. You need to have a strategy, have a plan B, you know, take a deep breath if you're starting to feel your emotions becoming elevated in these situations. And again, living in their reality, trying to understand what that patient with dementia, why are they trying to leave the home? And again, using distractions. So trying to redirect them. Let's go get a cup of coffee, you know, or little white lies. I always tell my patients are fine. Like, oh, the office is closed today. You know, maybe tomorrow you can check in later. Some of these techniques may help defuse the situation and de-escalate the situation so the person will be less likely to wander. And music can be very helpful. We know musical therapy can help a lot with just decreasing the heightened anxiety and restlessness too. So music is also a good backup as well. So again, like I mentioned, doing some detective work, you know, why is the person suffering from dementia confused and wanting to leave? Or again, are they looking for something familiar? Is the lighting in the apartment or the house dark so they don't recognize where they are? You know, and of course, our older patients also have visual issues too, so they're at more risk of not being able to interpret visually their surroundings. Are they bored? Are they just staying at home all day? So they're wandering. I would do that. You know, they may have a hard time remembering when caregivers tell patients to just stay there, sit down. Because of their dementia, they're going to have a hard time remembering that. So having someone around to help remind them that everything's okay is very helpful. Again, who are they looking for? Why are they wanting to leave the home? Again, understanding them and the situation is really important and takes some detective work. So what are some tips on how, again, once you have more information about why the person with dementia might be wanting to wander, what can you do? So again, don't leave the person unsupervised in a new environment. We know patients with dementia are very more comfortable and do better in a routine. So anytime they're in a new environment can provoke more anxiety, and that can then promote more wandering. So keeping a close eye on the loved ones with dementia, bringing familiar places, familiar objects, picture books and things like that, having Post-it notes that, oh, you know, I as the daughter will be right back. I'm going grocery shopping. I will be back at 3 p.m. Having those constant reminders can be helpful too, to help keep a patient more oriented and more safe at home. Providing a routine, providing a structure. You know, having meal times at certain times, having certain game times, music time, nap time, having all of these things scheduled can help, again, promote less anxiety for a patient with dementia, and thus hopefully help prevent, lessen the chance of wandering. And then again, physical activity is good too. We all know that. If there's an issue with incontinence and wanting to go to the bathroom a lot and getting lost going back and forth to the bathroom, creating like a toileting schedule or timed voiding may be helpful as well. So just trying to play detective work and come up with some solutions. But again, really the key is understanding why the patient suffering with dementia, why are they wandering, can be very helpful. So you always want to consider safety plan in advance. You want to have, you know, ideally have some sort of ID on the patient. If they remember to wear an ID bracelet, or always have their wallet on them with their ID is helpful in case they do wander. It is helpful to also have at home a backup, a recent picture of a patient who is at risk for wandering. So in case they do wander, you can distribute the picture to first responders to help promote to the community, to help find them sooner rather than later. Having some sort of GPS tracking device is also helpful too. So air tags are something pretty simple and cheap. And then having a list, not only having a recent picture of the loved one with dementia, but also having medical history and emergency contacts. So something really short on one piece of paper at home can be very helpful in cases of wandering emergency. So some other things for the home that can help prevent wandering are hidden locks. So hiding locks or child-proofing locks can help. So patients with dementia won't try to jimmy open the door. Again, making sure there's good lighting. So people with dementia can recognize their surroundings better. I have had patients, family members camouflage doors, so putting curtains over the front door. So hopefully out of sight, out of mind, the loved one with dementia won't try to exit through there. Having a door alarm is helpful, having fencing around the yard. And then again, just post-it notes around the house can be very helpful too, to reassure a loved one with dementia it's safe at home. Like I mentioned, with technology these days, there are the Apple AirTags, there are the regular GPS trackers, the medical alert bracelet with the emergency contact info in case a person does get lost, and a good bystander can help them. Having Alexa, I'm not too techie, but I know some of my families have Alexa that can help with reminders and help with have family can talk to the loved one at home with dementia through Alexa can be helpful. And then home video cameras, baby monitors as well. And then the last thing I wanted to talk about is driving. And this is always the hardest part of my job, is to counsel patients on when they can't drive. A lot of our patients with dementia don't have insight. There was a case where another gentleman last year with dementia who was still somehow found the keys to the car and drove to Home Depot, and then took the AirTag out of his wallet, left it in the car, and then wandered, and still has not been found. So for our dementia patients who are quite mobile or who have access to cars, this is really a serious issue when it comes to driving, because then they just have bigger radius of getting lost. So whenever a patient who has dementia, driving is a serious problem. And so it's not only the safety of the person driving, but of course others as well. They may, accidents, they may hit people and things like that. Especially if there's also not just cognitive, but also visual impaired ability, difficulty problem solving, easily distracted. All of these things will lead to unsafe driving. So when there are worries about that, I often tell families to do a ride along. So ride along with the person driving and do a road test to see, do you feel safe with them? If you don't, then they shouldn't be driving. You always want to offer ahead of time alternatives like handy van, go-go grandparent, and things like that. So it's not such a blow when the keys have to be taken away, and they have a backup plan to maintain their independence and other transportation options. You always want to, again, plan ahead. There are, if the patient allows you, you can refer to the DMV for a driving test, but the patient with dementia has to allow you. There are very limited now. I'm not sure if we have the Pacific is the only place now that has the driving test done by occupational therapy. But again, the patient has to sign an agreement that if they go through the driving test and they fail it, the OT is mandated to report to the DMV. So it's not the best plan. So it's really just having the conversation with the patients and the families to prep them to be aware of driving safety and have a backup plan. And if all else fails, I've had family members just take away the car or cut the cable, because I think taking away the keys isn't always that helpful and that easy. So there's always other options as well. And with that, I'm going to turn it over to LJ.
Thank you, Dr. Fujikami. Hard act to follow. I just want to make sure everyone can see my screen.
Yes, we can.
Yes, we can.
Great. I hope this is the right screen I'm sharing. Sorry, I'm working off of one screen today. Ivy, what screen can you see? Is it?
So it's a white background with the logo.
Oh, perfect. Thank you.
Sure.
Hello, everyone. Again, my name is LJ Duenas. I'm the Executive Director for the Alzheimer's Association. And thank you for spending your lunch hour with us. Like Dr. Fujikami had mentioned, wandering is a big concern for the population that we serve, and as the number of people who have Alzheimer's or other forms of dementia increases, we know that the incidence or the likelihood of more people wandering will rise as well. We know today that 6 out of 10 people will wander at least once, and many do so repeatedly. We've seen, and you've heard from Dr. Fujikami talk a little bit about William Burr, who went missing in November, and unfortunately, he was found deceased not too far away from his home. The gentleman in the middle, Mr. Frank Pinglinen, it's been over a year since he's been missing, and Dr. Fujikami had mentioned earlier about the gentleman that went missing at Home Depot. There were, video captures of him looking for his vehicle and trying to find his way back to his vehicle after he left the parking lot at Home Depot. Unfortunately, till this day, Mr. Frank Pinglinen is still missing. And then also on the Big Island in Kailua Kona, Miss Yunzang Yuthok is still missing till this day. She went missing, I believe they were on a hike, and she went missing in the lava fields. So, these are unfortunate situations that we've had to deal with some of the family members that are either still working or are still searching for their loved ones, or who've had to, unfortunately lose their loved ones to wandering and, them being found and deceased. And there have been, however, situations where many of the folks that have Alzheimer's or another form of dementia that do go missing are found as well. But, in order for us to make sure that our community is safe, and especially this, vulnerable population, this year we thought that it would be important that we prioritize a Silver Alert bill. So real quickly, a Silver Alert is a public notification system in the United States to broadcast information about missing persons, especially senior citizens with Alzheimer's disease, dementia, or developmental disabilities, in order to aid in locating them. Now, 15 years ago, the first piece of Silver Alert legislation was introduced. And this year, we were fortunate to secure the support of Senator Brandon Elefante, who introduced SB 2305 in the Senate. There was also a House vehicle that was also introduced by Representative Corey Chan. And what SB 2305 called for was to establish a Silver Alert program within the Department of Law Enforcement to help locate and safeguard missing persons who are 65 years of age or older, cognitively impaired, or developmentally disabled. The bill also called for appropriation. So it appropriated $250,000 to the Department of Law Enforcement to help them launch this program. Today, there are 37 states and the District of Columbia that has a Silver Alert program, and we're hopeful that Hawaii will be the 38th state. And so how does the Silver Alert work? Well, on a local level, the Silver Alert system works much like the Amber Alert or the Miley Amber Alert here in Hawaii. The missing person incident is reported to the local police. Personal health information may be necessary, and it should show that the person is over the age of 65, suffers from dementia, or is developmentally disabled. Relatives should also provide other details that would help in tracking down the missing senior or person. After verification, the police informs the state agency tasked to issue the alert. And in Hawaii, that would be the Attorney General. So the Attorney General is the clearinghouse for both the Miley Amber Alert, and if this legislation does go through, it would also make its way through the Attorney General before an alert is issued. So if approved by the Attorney General, a Silver Alert is then issued by that state agency, and the alert is displayed on electronic highway signs where those are available, broadcasted on radio and television, or even by cell phone or text alert. Is if you have a cell phone and you get a text alert about the weather, or if there was an Amber Alert in the community, it would work the same way. Now, the Department of Law Enforcement is still working on what this may look like once we are hopeful that the bill does go through. So on the local level, in April of on the 26th of April, last month, the conference committee did approve a bill that was agreed upon by the House and Senate, because there were two different versions that each chamber passed. And on May 3rd, the House and the Senate, full floor, did approve the bill to go to the governor. So at this time, we have been working with the governor's office to see when he may be able to schedule a bill signing ceremony with us and with the many partners that we partnered with to make sure that this goes through. We owe a lot of gratitude to the DD Council and many of the other organizations that have partnered with us, and families that have shared their stories, because those stories from families like the Burrs or Pangilinan helped us move this bill forward that has been in the works for over 15 years. So we know that Silver Alerts work. They have saved many lives in the other counties or states across the country that have them launched. And so we are more than certain that this will help alleviate any issues or any wandering situations that we may face in the future, and ultimately saving lives and heartache. So thank you for taking the time to spend with us, and I'm happy to answer any questions. And I'm not sure if Dr. Fujikami is still around to answer any questions from her presentation. But thank you. Thank you for your time and your attention.
Thank you, LJ and Dr. Fujikami. Does any of the audience have any questions or comments?
If I could just add, Dr. Masaki, we've been also successful in including dementia training for law enforcement personnel through their crisis intervention training. And so we thought that this would work hand in hand with the Silver Alert bill, being able to ensure that our first responders, our heroes, are trained in dementia, and making sure that they understand perhaps what are those instances, or how to handle situations when faced with someone with Alzheimer's or dementia.
Thank you so much. Very important. Any other thoughts or comments from any of our audience?
Hi, Dr. Masaki. It's Kapono. Can you hear me okay?
Yes, we can.
Hi, LJ and Dr. Fujikami. Thanks for the presentation. I'm Kapono, one of the fellows. I just had a question about the driving law in Hawaii, as physicians are not required to, or don't have like the authority to request to remove a license for a patient who we deem that may not be fit to drive. Is there any kind of movement in the legislature about reevaluating that, or kind of, is that a topic of discussion?
Yeah, it was tough when I came back home from California. In California, we were mandated. We could have them mandated, just like with infectious contagious disease. It's a public health issue. So in California, providers could report to the DMV without the patient's consent, if there was definitely strong concern about safety with driving. Unfortunately, yeah, here in Hawaii, I learned quickly that Hawaii doesn't have that law. I did with Dr. Kogan. When I first started here at Queens 5-6 years ago, we did try to work with the Queens legislative staff to try to do some advocacy, but it was quite difficult. If patients do give consent, then we can report and request a driving test through the DMV, but they have to give consent. So it's quite tough. I don't know if anyone
One
else has
way,
any experience.
yeah, one way I've gotten around that before is I've talked to the family, and often it's the family who's also very concerned and thinks that the patient should not drive. And if that's the case, I usually tell them, you can report. And they have. And then once the report goes in, then they have the DMV has mandated a driving test. Now, sometimes even when the license is taken away, some of these patients will insist on driving, right? So families have had to be very creative about making sure that the vehicle or the keys or whatever are not easily available, that type of thing. But it's not an easy solution. Anyone else have thoughts or comments about this?
Dr. Masaki, is it majority of states mandate it, or is it more common that our state is similar to other states that don't mandate it?
I believe it's quite mixed. Gina, do you know how many states, like in California, it's a strict mandate, right? You have to report, otherwise you're liable.
Yeah, not too, it's a good question, Capoto. I want to say maybe it was 50-50, but I'm not certain. Don't quote me on that.
I'm not sure either. I know it's extremely variable though.
But I guess that's a good tip, Dr. Masaki. You could kind of discuss with the family. If you folks don't feel that's safe, then you can, on your side, report to the DMV,
Right.
thinking about safety.
Yeah.
Okay, thank you.
Again, that could lead to the person's license being taken away. But, we know that people with dementia can have very poor judgment. So even if the license is taken away, they may continue to drive. So the family has to be quite creative. Any other thoughts or questions?
Yeah, this is Dr. Blanchette. Over the years, we've had a lot of cases like that. And working with families has probably been the most successful. And then giving them ideas about how to stop the person from driving. One of the ways is to disable the car. But sometimes the person just gets if the car is within the yard, they get very upset. So another way to do it is to remove the car. Say it has to be, it's in the repair shop. And if you keep it away from the yard long enough, they'll forget, you take advantage really of the fact they have a memory problem. They'll forget they ever had a car. So, but the important thing is to just take the car away so that they can't access it. And then what you have to do when you do that, and this is what families have a hard time with, is you have to provide alternative transportation. That means you have to take the person to the grocery store, to the doctor's office, to any place they want to go. So sometimes that's why families don't take it away when they should, because coming up with alternative transportation for that person means the family has to pitch in and help out. So taking it away out of the line of sight has been one of the most successful ones.
Thank you, Dr. Blanchard. That's very practical and useful.
Yeah, I don't know, want to share a personal story. Having had to do this with my father-in-law, not that long ago. It's a pride thing too, because he didn't want to give up his car. So he stopped driving, but he still owned the car. And it was very important for him to check the car every day. He had to check, I was driving the car. He had to check and make sure there were no dings and no, I was taking good care of the car and everything, was still his car. And I think allowing him that was helpful too.
Sometimes it can be an independence thing, like the car is really needed for transportation. In other cases, it's really not. but it's just a matter of, the person's feeling, right? The person's feeling independent, the feeling of pride or whatever. And you have to kind of address both of those.
It has to be the solution has to be very individualized.
Absolutely.
For a lot of people, the car being in the yard or available has been a source of problem because they insist they're going to take it. So, and the family doesn't know what to do. So, like I said, removing the car from the yard or from the place where the person resides has been very helpful. I remember one case where the person was very insistent upon driving, but they had been in a couple of accidents and the family was terrified. And what they did was they had a police officer come over and talk to the person about they weren't allowed to drive anymore. And that's it. They were very responsive to authority. And so they said, if the police said I can't drive, I can't drive. But it has to be, I can think of a lot of different cases where we've worked with this, tried to find out. Sometimes people who are mild to moderate dementia that are having problems driving are insist upon continuing to drive. And sometimes what we've been able to do is get them to agree to take a driving test. And if they pass the driving test, then fine. If they don't, then they'll agree not to drive anymore. And that's been helpful for a lot of people. Very individualized approach, depending upon the situation. But the answer has to be in providing them transportation so they don't try to rely on their car.
I guess, Dr. Blanchard, that would be my follow-up question. What are the transportation kind of resources for patients with dementia? Because is handy van only for like physical disability, or can a patient with dementia who can't drive be eligible for handy van?
They can be eligible for handy van, but if the dementia is bad enough that they're not very oriented, having them take it is a challenge unless they have a companion with them. Right? So if there's a pair and the driving spouse now no longer drives and the mentally intact spouse, they can take the handy van together. But if the person is very confused to even be at the place where the handy van is supposed to be at the time that they're supposed to be there, can be very challenging.
I see. So a spouse or a caregiver can join a person on the handy van?
Yes.
Oh, great. Okay.
Are there any other thoughts or questions, anyone?
Hi, this is Pedro. I'm one of the Jerry Fellows as well. Kind of just for LJ, congratulations on passing the legislation. It's like 15 years. It's such a long time to be able to pass something that is like obviously needed. I guess my question is like moving forward on the implementation side of things. Every time I see an Amber Alert, I think part of the issues I see with it is that there's no picture, right? It's only text, and you just get this notification, and I think everyone kind of doesn't know what to do with it. I wonder if there's like, if it's going to be exactly the same as an Amber Alert, or are there possibilities of like, sending out picture format of the missing person to cell phones? Is that kind of part of the development process, that in the next steps of implementation of this?
Yeah, thank you, Pedro, for your question. So the Department of Law Enforcement is going to be working on what that will start to look like, which is why we had to make sure that there were funds appropriated. And I believe, our discussion with them was because the Crime Stoppers does such a great job at putting information all together and then sending it out to the community for the various things that they do in trying to get information out more broadly. And so it could be a link to a photo or a posting of some sort. And so there's still going to be this opportunity for us to, of course, weigh in and see what other states have done and what has worked for other states that we could implement here as well for Hawaii. So we're excited to see what that's going to look like, and we hope that we will have a seat at the table as they begin to work out what that process is going to be for the state. But I have to say that the win really for this piece of legislation, that took 15 years, is really the families that came and shared their story, that testified in person or in writing. I mean, these were families that were many times in tears when they were sharing the experience and having to have looked for their loved one or continue to look for their loved one, or unfortunately had to make funeral arrangements because their loved one was found deceased. So really appreciate your question, Pedro, and if you're interested in becoming an advocate and helping us work with the Department of Law Enforcement on this, feel free to reach out.
We'll do. Thank you so much for that. I appreciate it.
Hi, this is Kiana, I'm a fellow as well. I guess in the meantime, for our patients or for the families, when someone does go missing, how do they, is it just they have to notify like the news outlets to see like what, because sometimes I'm watching the news and I do see, they'll report a patient who's missing. Is that just, they're not mandated, of course, to do that, but what is your recommendation in terms of, what to do now while we're waiting for this to play out?
Yeah, Catherine, thank you for your question. I would recommend calling 911. They will work with Crime Stoppers, or they'll work directly with the media to get information out as soon as possible. Because that's currently what the process is, right? Is calling 911, issuing or reporting a missing persons, reporting missing persons to the police, and then they will help get that information out to the media, to radio, and so forth. There's no coordinated effort, which is the challenge, and this is going to make that process a lot more simpler and more impactful in terms of just the ability to geo-target specific communities. Because if someone's going missing in at the Home Depot in Kunia, I think there's a Home Depot in Kunia, they could geo-target a 2-mile radius versus having to issue a statewide or county-wide alert. But Catherine, I would obviously recommend your patients or caregivers call 911 because they will work obviously with the media or Crime Stoppers who can get the information out to the media partners.
Even after the bill is passed, they still should call 911, I assume.
Yeah.
Right? Yeah.
So that was some of the families' feedback for their patients, for their loved ones that were unfortunately not found. It was just having, like you said, that immediate local response. Got it. Thank you so much.
Hi, sorry, another question probably for LJ. I know you mentioned that you're trying to get some effort also like for the police departments. I guess I was wondering if like social work is involved in going out with some of the police I guess personnel, like when they go out and maybe find some of these people, is social work involved at this point or not really?
Jenny, I'm not so sure. This is actually also going to fall under the Department of Law Enforcement, which is a fairly new state agency for Hawaii. And so I can certainly look into that and get back to you, but I'm not for certain if social workers are going out with these police officers when they're responding. I wouldn't imagine that they would, but it's a good point. Especially when dealing with other, issues, right, outside of dementia, mental health issues and whatnot.
And I only bring that up because I think in San Diego, I have a friend who's actually a social worker who mentioned that they were actually pairing up with some of these calls to go out into these sites to actually evaluate, because a lot of the times it was more of a social work assistance that actually helped versus, you know, I don't know, just law enforcement, right? Kind of part of that educating the police department on kind of geriatric care, I guess, in a way.
Yes, and you know, I don't know if anyone has participated in a ride along with the police officer. If you have, I mean, it's eye-opening. I went on two, and I swear 90% of what you're responding to is mental health issues. And I'm not sure if the police officers, you know, I'm going to assume that they get the training that they need, but they may not know what to do with some of the calls or the incidents that they're responding to, and then who to send them to if there's additional support that is needed, whether it's dementia or you know, mental health issues.
LG, do you know specifically what they will be trained in and who's kind of heading that training?
Yeah, Kapono, so it's gonna fall under the Department of Law Enforcement for the state. And I believe there's also a law enforcement standards board that is working on what the certification and training is gonna look like. I'll have to look into the bill in its entirety. It's a pretty long bill, and they're probably still working on you know, what training and certification is gonna look like. I can certainly, you know, follow up with Dr. Masaki on some of these questions that are being asked that I can't answer.
Sure. Like, is it being led by like law enforcement or medical professionals involved?
So it's falling under the purview of the Department of Law Enforcement, the State Department of Law Enforcement, and I don't know who they use for training.
Gotcha.
Many different county law enforcement agencies use different agencies or organizations to provide training. And I hope this one will kind of streamline and streamline training. So I can look into that and get back to Dr. Masaki.
Thank you.
Though usually these types of agencies, they get content experts to provide, to at least co-teach. It doesn't make sense to have a police person teach about dementia, right? But
Sure.
they could but they always get content experts.
Okay,
So
great.
several of us on faculty, we've given talks to lawyer organizations and bankers and law enforcement and people like that, because they need to understand and recognize dementia as well.
That's great.
For some people, they spend too many hours alone. In Hawaii, with so many families in the workforce, both husband and wife, or two partners in the workforce, the person with dementia is left alone too many hours during the day. And for some people, the answer might be to enroll them in an adult daycare program so that they're not by themselves with not knowing what to do with themselves. So you take a look at these issues and you have to solve them one by one. What's the best solution for this person at this time? But you can't forget that a lot of times people are bored, so they'll take their car and go somewhere and get in an accident or get lost. So if adult daycare is a solution for a person, it's one thing to think about. Now, I've never seen anybody who actually wants to go to adult daycare, but especially after the first day, by the second day, they want to go. And interestingly enough, we've had problems with people 5 days a week adult daycare, but people want to go Saturday and Sunday, and they don't understand that they can't go because it's closed on those days. So I don't think the resistance to going for the first time is actually where you stop.
Right. You're right, Dr. Blanchett. The majority of people, once they get used to it and once they start developing relationships with the staff and the other patients, they really enjoy it.
That's right.
So, yeah. Okay, if there are no other questions, we'll give back a little bit of time. And I again want to thank Dr. Fujikami and LJ Duenas for jumping in at the very last minute because our speaker was not well and covering this very important topic of wandering and dementia. Thank you, LJ and Gina. John, could you please put the link to the evaluations in the chat box? John has already done that. Thank you, John. So if everybody could please click on that, and you need to do that in order to get your CMEs. Hope to see you again next month. I do want to give a plug for next month's Grand Rounds. So June Grand Rounds is always our fellow presentations. So our June Grand Rounds, we'll have 3 presentations, one research presentation by one of our Geri Fellows, one will be a QI presentation by fellows, and one will be a medical student presentation on a research project as well. So hope to see you all in June, and thank you. Okay, bye-bye.